speaker, while relatively new in the CCHS community, is building his career around CCHS and is already making his mark on patient care and research. Dr. Ajay Kasi. Dr. Kasi is a pediatric pulmonologist at Children's Healthcare of Atlanta and is an assistant professor at Emory University School of Medicine. Dr. Kasi received his medical degree from Bangalore Medical College. He completed a residency at Nicholas Children's Hospital in Miami and a pediatric pulmonary fellowship with Dr. Keynes at Children's Hospital, Los Angeles. As a fellow, Dr. Kasi received the esteemed Chun I. Wang Award for Outstanding Pulmonary Research. In 2018, Dr. Kasi helped establish the diaphragm pacing program at Children's Healthcare of Atlanta. This unique program is specifically designed for children with CCHS and is one of only a few of its kind offered in this country. His research focuses on ventilatory management strategies in CCHS and cystic fibrosis early lung disease. Dr. Kasi is board certified in pediatrics and pediatric pulmonology and is a member of the American Thoracic Society, American Academy of Pediatrics, the American Academy of Sleep Medicine. Dr. Kasi also serves on the CCHS Network Research Advisory Board, a panel that reviews CCHS research grants for funding. Dr. Kasi will be talking about secondary complications in CCHS and the routine screenings needed in clinical care management of CCHS. Thank you, Dr. Kasi, and welcome.
Hi, everyone. I'm Dr. Ajay Kasi. I'm a pediatric pulmonologist at Children's Healthcare of Atlanta and Emory University. My presentation today is on non-respiratory complications and screening tests in congenital central hypoventilation syndrome. I have no conflicts of interest to disclose. The learning objectives for today's talk includes summarizing the non-respiratory clinical features in children and adults with CCHS, review the screening and surveillance tests in patients with CCHS, and to discuss a multidisciplinary approach to optimizing care in patients with CCHS. So CCHS is characterized by a failure in the automatic control of breathing. So patients have high carbon dioxide levels or low oxygen levels that is worse during sleep than when they're awake. There's also autonomic nervous system dysfunction, which we'll focus on during the remainder of this talk. CCHS is caused by a mutation in the FOX2B gene or the paired-like homeobox2B gene. This is a lifelong disorder. So CCHS is associated with abnormalities in the autonomic nervous system function. So the autonomic nervous system is a part of your nervous system that regulates involuntary processes such as controlling your heart rate, blood pressure, respiration, and digestion. So the FOX2B gene is important for autonomic nervous system development. FOX2B gene mutations are diagnostic of CCHS. There are two types of FOX2B gene mutations: the polyalanine repeat mutations, which is an expansion in the normal 20 alanine repeats in the range of 24 to 33, resulting in 2024 to 2023 PARM mutations. These are the most common, accounting for about 90% of CCHS, and the remaining 10% of cases of CCHS are caused by non-polyalanine repeat mutations, called as NPARMs. Why is this important? Because the type of FOX2 gene mutation generally correlates with the severity of clinical features and associated symptoms in CCHS. A study showed that increased number of polyalanine repeats or PARMs was associated with an increased number of symptoms of autonomic nervous system dysregulation. So CCHS is a disorder which has now been recognized as not just affecting your breathing. So several organ systems may be involved. It is a generalized disorder of the autonomic nervous system. So some of the organ systems involved could be the heart, wherein patients could have low heart rate or bradycardia, cardiac rhythm problems, such as pauses in the heart rate, called sinus pauses, elevation in the right heart pressure, called pulmonary hypertension. Even the gut could be involved, causing Hirschsprung's disease, motility disorders in both your upper and lower gastrointestinal tract, esophageal dysmotility, problems with regulating temperature, abnormal pupillary responses in the eye, tumors of the neural crest, neurodevelopmental delays. It is important to note that not all the clinical features of CCHS present at the same time, and it could present at different ages. So the CCHS and the gut. The most common is Hirschsprung's disease, which is an absence of the nerve cells or the ganglion cells in a part of the bowel. Most patients with Hirschsprung's disease usually present in the newborn period or during infancy with difficulty passing meconium, which is the first stool of the newborn, distension of the belly, constipation, vomiting, and bowel obstruction. Hirschsprung's disease can be seen in about 20% of patients with CCHS. This is more common in the non-polyalanine repeat mutations and patients with the longer alanine repeat mutation, like such as 20-27 palms and longer. However, it was even recently reported in the 20-25 palm mutation, suggesting that all patients with CCHS with constipation should be screened for Hirschsprung's disease, regardless of the type of FOXP2B mutation they have. So the tests that could be used to assess for Hirschsprung's disease include barium enema, anorectal manometry, and a rectal suction biopsy, generally performed in conjunction with the gastroenterology doctor and the surgeon. Other gut motility issues can also be seen. Esophageal dysmotility or dysmotility in your food pipe. Patients can present with trouble swallowing, especially solids, a sensation of food getting stuck in the throat or in the chest, vomiting, trouble gaining weight, and pneumonias. Constipation, gastroesophageal reflux, which patients can present with vomiting, frequent regurgitation, and swallowing discoordination. And some patients with swallowing dysfunction may need a feeding tube. Evaluation by a gastroenterologist may be required if patients have any of these problems. CCHS and the heart. The most serious complication are cardiac rhythm problems or cardiac arrhythmias. Patients can present with fainting episodes called syncope, dizziness, chest pain, palpitations, which are sensation of abnormal heartbeats. In some patients, it can be severe enough that it may require a cardiac pacemaker implantation. It is important to note that this at different ages, including during adulthood, and can be seen in many types of FOXP2B gene mutations, including the relatively less severe 20-25 pounds. So all patients with CCHS may be at risk for cardiac rhythm abnormalities and should undergo ambulatory cardiac monitoring, which is recording of the electrical activity of the heart, generally performed during a 72-hour Holter monitor study or a Zio patch study. In addition, patients can also have low heart rates called sinus bradycardia, reduced heart rate variability, lower maximum heart rate with exercise compared to healthy children. There could be blood pressure abnormalities such as low normal daytime blood pressures, orthostatic or postural hypotension, wherein when one stands up from the sitting or lying down position, they can experience low blood pressure, leading to dizziness and sometimes fainting. Pulmonary hypotension can also be seen, which is increase in the pressures in the right side of the heart. This generally occurs because of abnormal oxygen levels or CO2 levels, which may be undetected during the daytime, or inadequate ventilator settings during sleep, or not using the ventilator regularly and normally like they should, so reduce compliance. So this is evaluated by an echocardiogram. Evaluation by a cardiologist may be required when patients have any of these symptoms. Patients with CCHS can also experience some problems during exercise. Patients can develop low oxygen levels or high carbon dioxide levels during exercise, despite having normal levels during the daytime and at rest. We recently performed a study of 15 patients with CCHS, where they performed a 6-minute walk test with oxygen and CO2 monitoring. We found that all patients had a decline in their oxygen saturations and an increase in their carbon dioxide levels compared to before starting the test. So this picture here shows the CO2 levels and the saturations and the FOX2B gene mutations. So the blue line represents the oxygen saturation cutoff of 90%, and the red line represents the carbon dioxide level cutoff of 50. As seen in this image, patients with different FOX2B gene mutations had intermittent low oxygen levels or high CO2 levels during exercise in the 6-minute walk test. So hypoxemia and hypoventilation, which is elevation in the CO2, were identified in patients with both the shorter, such as the 2025 and 2026 PARMs, and the longer PARMs, such as 2027, suggesting that all patients with CCHS may be at risk for gas exchange problems with exercise. We also compared the lowest oxygen level and the highest carbon dioxide level based on the different types of FOX2B gene mutation. And we identified the difference based on the FOX2B gene mutation. During this study, none of the patients reported any symptoms during or after exercise, despite having some low oxygen saturations or high CO2 levels. This inadequate sensation of dyspnea or shortness of breath, along with the problems with oxygen and CO2 levels, highlights the importance of monitoring the oxygen and carbon dioxide levels during exercise. So exercise tests may help your physician formulate a safe and personalized exercise plan for each patient. The other problems with autonomic dysregulation include severe constipation, reduced perception of discomfort and anxiety, profuse sweating, reduced body temperature, cold fingers and toes, and pupillary abnormalities in the eye. Additionally, patients with CCHS are also at risk for neural crest tumors. These are tumors which can occur anywhere in the neck, chest, or abdomen, and includes tumors called as neuroblastoma and ganglioneuroblastomas. The risks for these tumors are much higher in patients who have non-PARM mutations, or in the range of 45 to 50%. Patients with the longer PARMs, such as 2028 to 2033, are also at risk, but the risk is a little lower compared to patients with NPARMs. Therefore, tumor surveillance is important for early identification and treatment of these tumors. These tests may include a chest X-ray, an abdominal ultrasound, and urine tests. These tests may be performed more frequently until 6 years of age and less frequently between 6 to 10 years of age. Generally, no tumor surveillance tests are recommended after 10 years of age unless recommended by the oncology doctor. If any tumor is identified, it may need excision or biopsy by the surgeon so that the diagnosis can be confirmed and an appropriate treatment plan can be formulated. Patients with CCHS may also have complications with anesthesia. General anesthesia medicines, sedatives, and opioids such as pain medicines can suppress the breathing and cause respiratory depression. Risks that can happen during the procedure include cardiac rhythm problems, low oxygen saturations, high carbon dioxide levels, and low body temperatures. Therefore, it is important to have a plan before surgery, which includes discussion with the surgeon or the dentist, the pulmonologist, the cardiologist, and anesthesia doctor. A thorough preoperative evaluation is recommended. Before the surgery, an EKG or an electrocardiogram, which measures the electrical activity of the heart, an echocardiogram may be required, and discussion with the cardiologist if the patient has a cardiac pacemaker. Some patients may require preoperative sedations or anxiolytics before the surgery. Generally, we avoid using them. However, if it is required, it can suppress their breathing. So we suggest that patients use their ventilator and the pulse oximeter if these medicines are given. Even following surgery, patients may have suppressed breathing because of the effects of general anesthesia and sedation. So we recommend using a ventilator to maintain normal oxygen and CO2 levels, and also to monitor their oxygen and carbon dioxide levels after the surgery. An important note is about CCHS and alcohol and drug use. Alcohol and other illicit drugs can cause respiratory depression. This can cause severe adverse events, including coma and death that have been reported in patients with CCHS. Some patients may have a lack of anxiety and may not be able to perceive dangerous levels of oxygen and CO2 levels in their blood, especially after consuming alcohol. They may forget to put on their ventilator, and this may cause serious harm. So preemptive counseling about alcohol and drug use and respiratory depression should be started in the early adolescence period, and patients should be counseled about the dangers of alcohol and drug use. CCHS in the eyes. CCHS can be associated with strabismus or misalignment of the eyes, pupillary abnormalities in the eyes, wherein there could be abnormal dilation of the pupils or unequal pupil size between the two eyes, ptosis, which is drooping of the upper eyelids, inadequate tears. So the recommendation is to see an ophthalmologist once CCHS is diagnosed, and then perform annual evaluations with the ophthalmologist to identify any of these problems, since identification and early treatment may help correct some of these abnormalities. Some patients may require corrective lenses or surgery if these are identified. Patients with CCHS are also at risk for neurocognitive and developmental delays. The speed of processing and working memory may be affected. Breath holding spells, need for 24/7 ventilation, prolonged sinus pauses, and seizures may be related to the severity of the neurocognitive delays. The FOX2B mutation type and the ventilation method may also be involved. Therefore, comprehensive neurocognitive testing should be performed at diagnosis and annually, so that if these are identified early, treatments can be started. And neurocognitive delays can be identified pretty early, even in preschool children. In this study of approximately 200 patients with CCHS, they found that neurodevelopmental issues were found in approximately 45% of patients, including developmental delays, learning disabilities, attention deficit hyperkinetic disorder, which is ADHD, speech and motor delays, and some patients may require speech and physical therapy. Ensuring good oxygen levels and CO2 levels are very important to maximize the full neurocognitive potential. So the ventilator settings may need to be checked and adjusted periodically to help with this. Early identification and intervention for neurocognitive delays are important so that children can catch up on their developmental progress. Rarely, CCHS can also be associated with endocrine problems. Not much is known about this topic, but there could be associated blood glucose or blood. This may include hypoglycemia, which is low blood sugar, hyperinsulinism, or increased insulin levels in the blood, and patients can present with seizures. In some patients, despite low blood sugars, they may not have symptoms. Some patients can also have high blood sugar levels or hyperglycemia. There's only one patient reported with growth hormone deficiency and hyperthyroidism. So some patients may require to see an endocrinologist if these occur. So until now, we discussed that not all the clinical features of CCHS can present at birth or at initial diagnosis, and some clinical features can present at different ages, including during adulthood, and therefore these patients require these serial routine surveillance studies, and regular surveillance studies are important to identify early clinical features and to formulate an individualized plan of care for each patient. This table here shows the recommended evaluations in patients with CCHS in terms of the breathing, comprehensive testing of oxygen levels, CO2 levels, respiratory rate, heart rate during sleep and during wakefulness should be performed in a sleep study. In those less than 3 years of age, these are recommended every 6 months. And after 3 years of age, they're recommended annually in all patients with CCHS. Cardiovascular, the ambulatory heart cardiac monitoring, which is the electrical monitoring of the heart rhythm for at least 72 hours. Blood pressure and echocardiogram monitoring should be performed annually in all patients with CCHS. Gastrointestinal. In patients presenting with constipation or abdominal distension, barium enema, anorectal manometry, and confirmation of the rectal biopsy for Hirschsprung's disease should be performed, generally at initial diagnosis, and later on too, if any symptoms appear. And these are generally seen in patients with 20/26 palm and long and end palms. Comprehensive neurocognitive testing to assess neurodevelopment should be performed every 6 months in children less than 3 years of age and annually thereafter in all patients with CCHS. Tumor evaluations, we're using a chest radiograph, abdominal ultrasound, and urine tests should be performed every 3 months in children from birth to 6 years of age, every 6 months between 6 to 10 years of age, and after 10 years of age per the oncologist's recommendation. And this should be done in all patients with NPALM and PALM's 2028 to 2033 mutations. A detailed, thorough eye examination by an ophthalmologist should be performed at diagnosis and annually in all patients with CCHS. This is important because there could be changes in care based on these annual evaluations, even if children are asymptomatic. We recently performed a study of 10 patients with CCHS who required ventilator only during sleep via tracheostomy or diaphragm pacing, and these patients underwent a sleep study or ventilator titration in the hospital with monitoring of their oxygen and CO2 levels. Among 10 patients, 7 of them, or 70%, had abnormal oxygen or CO2 levels and required a change in their ventilator settings or duration on their ventilator. Among these 7 patients, 6 required an increase in their ventilator settings, and only 1 required a decrease in their ventilator settings. And patients who reported symptoms such as headaches, desaturations during sleep required an increase in their ventilator settings. This is important because abnormal oxygen and CO2 levels can be associated with neurocognitive delays and pulmonary hypertension. Therefore, regular annual respiratory evaluations are important in patients with CCHS to optimize the oxygen and CO2 levels. So we discussed that patients with CCHS may require multidisciplinary collaborative care with different specialists. So this may include the sleep medicine doctor, the ear, nose, throat doctor in patients with a tracheostomy tube, the cardiologist, the gastroenterologist, the oncologist, the primary care doctor. And this coordination of care may be challenging for the patients and families. Therefore, the pulmonologist generally takes the lead in care coordination for patients with CCHS. This slide here shows the different specialists that may be involved in the care of a child or adult with CCHS and their different roles and responsibilities. I'm going to have you take a quick glance at this. So in summary, the take-home points are CCHS is not just a disease affecting breathing. All the clinical features of CCHS may not be present at birth, and some clinical features can present at different ages, including during adulthood. Therefore, periodic surveillance tests should be performed. Each area of care and organ system interacts with another and influences the overall health of each individual. Therefore, coordinated multidisciplinary care is vital to ensure the best healthcare outcomes for patients. So I'd like to conclude my presentation here, and thank you very much for listening to this presentation. I want to thank the CCHS network, Melinda Vichitelli, for this opportunity to speak, and to all the CCHS patients and families. Thank you.